Let's kick things off. Welcome to today's Brown Bag. This is a series of events that we host to help us to drill down into complex topics that we are often discussing and advocating on behalf of. And these can be, these really are educational. So please feel free to ask questions and submit questions as any come to mind. But we're really excited today to talk to you specifically about biosimilar medications and really how they are impacting the conversation of access and affordability around diabetes treatment. So let's roll to the next slide. For those of you joining us for the first time, DPAC is a nonprofit dedicated to advocating on behalf of patients and with patients to make sure that Congress and state legislatures are passing meaningful legislation to help people with diabetes. We have DPAC advocates or champions in all 50 states, folks with type 1, type 2, parents of children, family, friends. And our focus, again, is particularly on affordability and access to treatment and prevention. And part of our mission is empowering each of you to be advocates. And to do that, we have all kinds of events. I mentioned today as part of our Brown Bag series, where we break down topics that we're mentioning in other forums that we don't often have time to go into a lot of detail on. But we also have state forums, which is where we come to your state and work with your state legislators to pass legislation. We include our champions in those conversations and also dive into the topics that are impacting state legislatures across the nation, as well as Hill Days. And that's a congressional event that we host a couple times a year. We actually have one coming up in a couple months this summer. So please stay tuned for that. That's a good opportunity for everyone to participate regardless of your state because it is a congressional event. Next slide, please. Just a couple of housekeeping notes. This meeting is being recorded and can be accessed via Facebook Live, as I mentioned. If you've got any question, please submit them. We would love to answer any and all of your questions. And then we'll have a survey after today's event that we'll have for you to fill out. I'm going to just briefly introduce myself. I'm Julie Babbage, the Executive Director of the Diabetes Patient Advocacy Coalition. And joining me today, we have Erica Emerson, who is the Executive Director of the Diabetes Leadership Council, DLC, which is our affiliate organization. And she's going to be largely leading today's conversation on biosimilars. DPAC is the advocacy arm. We have champions and advocates, again, in all 50 states. DLC is the policy piece of this. They're really like a think tank almost for diabetes policy and legislation, and are really good at digging deep into the weeds here and unpacking some of these more complex topics. So I'm really pleased to have Erica on today, and I will turn it over to her and switch to our next slide. Thank you.
Thanks, Julie, and thank you to all of you for joining us today for our Lunch and Learn on biosimilars. We know it's a new topic for a lot of you, so we aren't going to wade too deep into the weeds, but we are going to wade in a little bit. We want to make sure that everybody on the call today understands what biosimilars are, why they matter in our advocacy, both now as it impacts the affordability of insulin and other diabetes medications, and going forward. Biosimilars are relatively new in the United States, and we expect more and more of them in years to come. So this is the right time to start, again, these sort of basic lunch and learn sessions to make sure when we advocate, we understand what these products are, why they're important, and how to work them into our advocacy. So first, let me just say I am not a scientist, I'm not a doctor. So we are going to keep this at a layperson's view of what a biosimilar is. If you're looking for the scientific point of view, you're in the wrong session. Again, we're going to try and keep this as light as we can. So a biologic medication is made or derived from living cells. That could be protein, or it could be derived from a protein, from a gene. Again, we're talking about super scientific methods to derive these new medications. When we call them biosimilars, they are similar to other FDA-approved medications, and there's no meaningful difference in their safety, in their potency, in their purity. So these, again, are perfectly safe and effective medications to treat diabetes and a lot of other chronic health conditions. Part of the reason they're important and part of the reason we're talking about them today is that biosimilars play a very important role in moving us all toward more affordable insulin and other diabetes medications. As we've seen more of these products enter the market, insulin net prices are actually dropping. Now, we'll get into this in a minute, how that might not be following through to what you're paying at the pharmacy. So sit tight and we will get to those questions in a moment. Jacob, if you can bounce us to the next one, perfect. So when we're going back and forth on how to explain what the differences are between generics and biosimilars, we had to go with pictures. So basically, I think a lot of you are familiar with generic prescription drugs, right? It's a pill. So you might start off with a brand medication, but eventually the older those products get, like Tylenol, eventually acetaminophen is available. It's the generic version of that small molecule chemical drug. So we think about it like a bicycle. It is fairly straightforward, few moving parts. And when we look at a generic, they're relatively easy to copy. Biologics, on the other hand, because again, they're derived from genes, cells, living tissues, they're really complex. There are a lot more pieces and parts, and they're harder to copy. So in that context, when we're talking about biologics, we're talking about a reference biologic, which is the term for the first one, basically the first product, and then a biosimilar, which is a copy or a close copy of that product. For the shorthand version, and the way it makes sense in my head is to think about prescription drugs are usually pills that you swallow. Biologics are usually medicines that have to be infused or injected. So in this case, oh, sorry, Jacob. So again, going back to our analogies, cars, if we look at the cars as a biosimilar, we have here the Lexus and the Toyota, both great cars, but a lot of component pieces and parts that are just going to be harder to copy. So that Lexus might have flashier advertising and more to back it up. But the Toyota, again, still a great vehicle, but perhaps doesn't have quite the same brand cachet. There we go. So what does this mean for people with diabetes? Again, what we're seeing is biologics are really important for bringing down prices at the pharmacy, which is where it really matters to patients. So on the left, we see the insulins that you're probably most familiar with, Humalog, Novolog, Lantus. The sticker prices that you see are literally that. These are the sticker prices that the manufacturer sets for their product. It's the starting point for negotiations. Now that we have biosimilar versions of those innovators, as you look to the right, that is what's happening to the list price for these newer products. So if you are accustomed to taking Humalog, your other alternatives right now that could save you money if they're covered on your plan include Admelog and Insulin Lispro, which is the same product from the same manufacturer as Humalog, but it's basically repackaged with a lower list price. We have Novolog, which you might be familiar with, is also available as an unbranded alternative. And when we talk about Walmart insulin, which we know is really concerning for people, it's an older insulin that is not necessarily as familiar. It's important that people know that Novolog is now co-branded with Relion. That is the analog insulin that is available now for $73 instead of retailing or being available through insurance at $300 or more. And finally, with Lantus, that is the product where we see some really interesting impacts on pricing and availability. There are several alternatives for Lantus, and we'll get into just a minute how messed up our system is that when that product was introduced, they actually had to increase the cost to get it covered on formularies. So when we talk about that last product, Semglee, or insulin glargine, YFGN. No, that's not a typo. That actually is how the FDA designates the name of that product so they can tell that it's different or its manufacturer is different than the innovator one. So interchangeable biosimilars are, again, relatively new. Actually, this is the first interchangeable biologic was approved in the United States just last year. And the interchangeable designation at a high level, again, just means that that manufacturer has provided additional studies to the FDA that demonstrate that patients can safely switch back and forth. It doesn't mean that it isn't necessarily safe to switch other products between the reference and the biosimilar. As people with diabetes, you are accustomed to having to change insulin all the time. It doesn't mean that that isn't safe. It just means that that manufacturer has provided additional evidence to demonstrate that, again, that is safe, safe to switch back and forth. Those two copies, even though they are similar and not the same, are as close as science will let us get between the two products. Again, we want to make sure people understand that all biologics and biosimilars approved in the United States meet the same strict FDA standards for safety and efficacy. The important thing is that you have access to affordable access to the insulin that works for you. And again, as we see more interchangeables coming into the marketplace, it might not necessarily change how you access your insulin day to day, but at the pharmacy, it could mean it's a lot easier to get those interchangeables substituted by the pharmacist without having to call your provider to have them change the prescription and go through all that rigmarole. So as we saw in that slide that had all of the different products and how those lower list prices go as there are more products in the marketplace, we see that play out in insulin as it does in other product classes. Again, with generic drugs and brand drugs, the more generics that are available, the lower those prices get. More options mean more competition and means lower prices. The question is whether or not those prices are getting passed along to the patient at the pharmacy where it matters the most to all of you. Biologics right now tend to be more expensive than a lot of brand chemical drugs. And they are 2% of prescriptions filled in the United States, but 40% of our prescription drug spending. We want to make sure that biosimilars are adopted rapidly because their average price is about 30% less than the innovator, saving patients and the healthcare system billions of dollars. So why aren't you seeing these on your formularies? If a product retails for $70 some as the list price, it's because the health plan and your plan sponsor, for example, your employer, are setting up the formulary in such a way that they make more money, but they aren't necessarily sharing those savings with you. So here, for those of us, or those of you who've been on our some of our lunch and learns before, we talk a lot about rebates. And we talk a lot about this system that right now is incentivizing costs to go up or list prices to go up instead of down, at least from the patient's perspective. So how that plays out in biosimilars and biologics, you have those reference drugs. We kind of rounded these numbers up to make the math a little bit easier. Say a product retails, the innovator retails for $300, and there's a cheaper alternative, a biosimilar, that lists for $200. Now, in order for those products to be available to you via insurance, the manufacturer has to provide a rebate or an incentive to the health plan or the PBM. That is how they get access to the drug formulary, which is basically the list of drugs that a health plan will cover. So they need to make sure their product, one, gets on that formulary, and two, they need to pay to get that placed favorably. So basically put in a lower tier where patients are more likely to take it or to use it because their costs will be lower. So if we look at how much rebates take up in our healthcare system or take up of that list price, it can be upwards of 70 or 80% of the list price for insulin. Again, how much these products actually cost a health plan versus what patients are paying at the pharmacy is a huge disconnect. So basically, a health plan or a PBM can collect $300 by covering the higher price drug. And so they leave the lower cost drug off the formulary because the rebates are lower. So we are all familiar, or hopefully we're all familiar with how tiering works in insurance coverage. We want to make sure, because biosimilars, just like generics, are such an important part of keeping costs down for patients, we want to make sure that insurance plans are covering generics and biosimilars appropriately, putting them in those lower, more accessible, more cost-effective tiers, instead of making biosimilar manufacturers compete with the brands. We don't want them to have to pay higher rebates. We want all manufacturers to compete based on the lowest cost. And then we want to make sure that insurers are held accountable to making those products available. Part of the way this country addresses the overall cost of prescription drugs is we need those alternative products introduced. We need them available and approved in the United States. We also need to make sure that they have a smooth glide path, easy access onto drug formularies, because that's the only way that insured patients will have access to them. So again, when we look at the consequence of these kind of perverse financial incentives in the rebate-based system, we see time and time again that these lower cost products are not making it onto formularies in Medicare Part D, which is the federal program for seniors and disabled Americans. And they're less likely to make it onto employer plans and Affordable Care Act plans. So in Medicare Part D specifically, there's some studies that are out recently demonstrating that new generics launched, even though they launch at an average savings of 30%, only a quarter of them are covered on Medicare Part D formularies in their first year. Less than half of generic products were placed in generic tiers. Again, those generic tiers where there might be no or low cost sharing, instead of higher tiers where you might have to pay full freight or even a marked up cost. Over the last decade, this is really concerning. The coverage on generic tiers dropped from 93% of available products to 43%. So less than half of available products that could save patients money are making it onto these formularies. That tells us, one, if you're a patient, you get to be mad. And as advocates, it means we have a lot of work to do. It's a complicated problem. They're not necessarily quick fixes, but this is how advocacy matters. We want to make sure that those savings are flowing to patients.
So Erica, I'm coming on just to drive home this point, because I think we've got some questions on how is it that that a company, that a middleman isn't wanting to cover a lower cost drug. Wouldn't they save money if they did, is essentially the question. And that goes back to the rebate discussion that we're having. So a lower cost drug is actually not saving money for the middlemen because they are benefiting from the higher cost drug rebate. So just was going to revisit this graphic with you. And also somebody pointed out that the patient is still paying the list price. If you see that third box on the left-hand side, oftentimes we talk about something called rebate pass-through, where the patient actually isn't getting the advantage of the negotiated price. And so absolutely patients get to be mad because in this process, we are suffering.
Exactly. You know, when we look at where these entities make their money, they make it on that spread. One of the best quotes we saw, and someone who's way more expert in this field than we are, he said, where there's mystery, there's margin. Or where there's margin, there's mystery. So because there's such a lack of transparency in the system, we don't always know how much that spread is. And that's part of why the system perpetuates. It's not just health plans and PBMs that make more money based on that spread. There are entities throughout the supply chain that make more money the bigger that spread is on drugs. So there's no incentive for them to cover the lower cost ones, and it's patients that end up paying the price.
Right. Nobody in this three-player system, and then multiple players beyond that, seems to be wearing the white hat or carrying the patient flag. We also got a good question just to revisit the tiers slide, because this is a lot of information. It's a good point. Just explaining those tiers once more, and helping to draw why tier 1 and what it means for a patient to have a drug that's covered in tier 1 versus tier 4.
Exactly. So I think for a lot of people who have insurance, obviously everybody's health plan structure it can be different, and that really is a matter of your employer, your union, whoever that plan sponsor is. They contract with a health plan and a PBM to kind of set up that structure. So ultimately, they're the ones that determine which drugs get covered and how much you end up paying for it. So when we look at how those formularies break out, those lists of covered drugs, the lower they are on the tier, it basically means they're more preferred. They might be lower cost. So they want to encourage patients to take those drugs. So a lot of generic drugs will be on tier 1 or tier 2. They want you to take the generic drug instead of a brand drug. So they might place that brand drug on a higher tier. So your cost sharing would be $500, or in some cases more. Again, you might be paying full freight for those drugs if there's a generic alternative available. Basically, what manufacturers try to do is pay the health plan and the PBM to get their product placed on those lower tiers. So your cost sharing is lower, and you're more likely to take it.
Got it. And I know this conversation comes in as well to the congressional legislation too that we're working on, but hopefully that makes a little bit more sense to folks. And then I'm looking at another question. My plan sponsor is it looks like a plan sponsor in California. Optum RX is my PBM. Who should I direct my advocacy to include biosimilars?
In that case, we recommend that people advocate with HR. So the Diabetes Leadership Council, in addition to our kind of government-focused advocacy, we work a lot with employers. And what we have found is most employers, not all, but most employers, when they know better, they do better in terms of their understanding of diabetes and how it's covered. They might not realize how expensive and how complicated it is for people with diabetes to manage their regimen. And they simply might not know that biosimilars are available, or that they're not being covered on their formulary. Sometimes it just takes an employee stepping up and making them aware that they're having affordability and access problems. So again, when those employers know better, they do better. They change their coverage to make diabetes management easier and more affordable. Instead of placing the necessities that you need, frankly, pricing them out of reach. If DLC and DPAC were structuring health plans across the United States, all diabetes management essentials would be available, no cost, pre-deductible, no copay. That we think that is the most cost-effective and frankly equitable way to cover diabetes management. Our country is not there yet. We're still working in that direction. So we're working with the system we have to make sure that employers understand that they play a really important role in making diabetes management affordable.
Right. And a lot of these conversations happen at the pharmacy counter as well, where you're saying, is there an alternative, and how, I need help to afford this insulin, or I need a more affordable option. So we know that and then advocacy as well, it takes place, of course, in Congress and in state legislatures. We have two specific bills, or rather, I'll let Erica speak to this, but we've got work that we've been doing on this front to try to make sure that not only are biosimilars able to come to market, but that they're also going to be covered appropriately, so that they have a better shot of, even if they're coming to market a lower list price, that they still have a shot of being covered, even though they can't offer that big rebate that the more expensive drugs can. So Erica, could you speak to what's passed and pending?
Sure. So one of the bills that has passed is called Advancing Education on Biosimilars Act. That is relatively new. So I think what we'll be seeing is more communication from the federal government and perhaps a lot of state governments as well, to help patients learn about biosimilars, to help healthcare providers understand biosimilars, to make sure that they're comfortable prescribing them and patients are comfortable taking them, that they trust that these products, again, are safe and effective and might save them money. So that really is just, that's awareness raising, because again, these are relatively new in the marketplace. Pending bill, and frankly, there are a lot of pending bills, but this is one of the most important ones for that, providing that on-ramp we talked about, making sure that approved products actually have a way onto formularies. There's a bill in the House that we're hoping will make it over to a Senate companion as well, called Ensuring Access to Lower Cost Medicines for Seniors Act. And this is really just making sure that Medicare formularies cover generics and biosimilars when they're lower cost and when they're available. We want generics and biosimilars placed on generic and biosimilar tiers instead of imposing those higher costs or making them compete with the brand companies and their higher rebates.
Right. So if you have a separate tier where these lower cost drugs can and should be covered, then they don't have to compete with the tiers that are with the drugs in and maybe a specialty tier or brand tier that are going to be more expensive just in their nature, but able to offer that bigger rebate.
Exactly. We want Toyotas on the Toyota tier and the Lexus in the higher tier.
Yes. Yes, great way to say it. And that bill, by the way, is 2846, HR 2846, and it's something that we've been advocating for and will continue to advocate for. And thanks for switching the slides, because that does take us into the federal landscape overall. So there's a lot happening right now on drug pricing conversations in Congress, and that's thanks to us, thanks to you, specifically to patients and advocates all across the nation who have said, we are sick and tired of this model. The American system is completely backward, and it's the patients that are suffering, and we're not going to take it anymore. And so lawmakers are really listening, and we know that they are working on it at state levels, and again, even in Congress, it's boiled up, and there are a lot of proposals out there floating around right now. We are supportive of low predictable cost sharing, and specifically there's a cap that Congress has been proposing that I'm sure many of you are aware of, that mirrors the senior savings model that came in a couple years ago, that was $35, setting that cap on a copay that a patient would pay when they go to pick up their medication. But there are other solutions as well that we think are going to be part of the mix going forward, regardless of what happens with the insulin cap legislation. We mentioned HR 2846. That's that tiering of generics and brand, biosimilars and biologics. There's also insulin rebate pass-through that Congress is looking at. That's where that giant discount that the manufacturers are paying to play in this system that we are in gets passed through to patients at the point of sale, so that you're not paying list price when you're still in your maybe deductible or pre-deductible period, that you're able to actually access the medications for what the plans have paid for them. So that's something we're supportive of. And we're having meetings across the spectrum in the House and Senate with Democrats and Republicans to make sure that diabetes and insulin are front and center for the conversations that they're having, and so that they understand just how important it is to not just be talking about a cap on copays, but on so many other things, in the system. Because we often think about, we have this one solution here, which is the copay cap. Then we have the rebate system. We have the question of formularies, meaning that low-cost insulin still may or may not be covered. We have people, many people in this diabetes community who are uninsured. And so what are the solutions for them? So there's no one overall panacea for our community. And we want to make sure that all of those options are considered. So even if the copay cap passes, which we will celebrate and which we support and which we are advocating on behalf of, we still have more work to do. And so that's the message overall, just on some of the things that are happening live. I want to just go back to questions here in our conversation. Somebody wrote in that just because a drug is less expensive doesn't mean it works for the individual. That is an excellent point. And Erica, I know that's something we speak to a lot. And I know you mentioned it earlier in the presentation, but I just want to give you another minute to hammer it home just so that we make that perfectly clear.
Exactly. The most cost-effective insulin is the insulin that works best for your diabetes. And as the person with diabetes, you know your body best. So ideally, again, we want to make sure that every person with diabetes has access to the care that works for them. But we do need to operate in the system that we have. And again, there is no one solution for everybody. So if your health plan covers an insulin that doesn't work for you, you need to be your best advocate. We wish it wasn't, there weren't so many hoops to clear, but that means talking to your healthcare provider. It could mean talking to your HR department. Again, you know your body best. So we want to make sure that you understand that there are tools available to help you have those conversations. DLC has some of those tools. JDRF has some of those tools as well. Actually, several other diabetes organizations have a lot of worksheets, tools to help guide you through those conversations, to help you not just change your circumstances, but possibly change coverage for other people with diabetes who are in your health plan as well.
Yeah, I think that's a great point. And oftentimes, in the discussions of state and congressional, we realize that there are populations that are still not being served by copay caps that pass in the states, copay caps that pass at a federal level. We spoke about the uninsured, but there's also ERISA, and somebody made the point too in their comments just now that employers are often in the driver's seat, and that's what Erica is speaking to, and particularly the DLC resources and conversations that we have directly with employers to help them understand that the entire landscape of this and how specifically diabetes fits into it and what to do if they really want to help their employees with diabetes. I want to be mindful of the time. I know that you may be joining us for part of your lunch, and we really appreciate that, or wherever you are in the U.S. Maybe it's breakfast. But thank you so much for coming together with us today. If you still have comments and questions that we didn't get to, we'd love to hear from you. We're going to send a follow-up email with a survey. We know that biosimilars has been something that you've been asking us to learn more about, especially because it's a topic that we are continuing to talk about. And we want to make sure that everybody really understands it so that you can speak out on behalf of it. You can tell your friends and family, you can help everybody in your community understand why this is so important. Because a lot of times, even with the name of bills, Congress gets tricky, or the things that we say are really nuanced and niche. And so it helps for us to all be understanding these complex subjects. And you'll have a minute too on your survey to tell us if there are other topics that you're hearing being discussed that would be really helpful to have this 30-minute sit down to unpack a little bit better. So thank you again so much for joining us. Thank you to Erica and to DLC for being here with us and for walking us through this very complex topic in a really efficient manner. I know for sure the bikes and the cars are going to stick with me. The Lexus and Toyota model is going to stick with me. So that really helped, I think, drive home just in an understandable everyday way, sort of just what we mean when we say why there is no generic insulin, right? What that really means. So thank you so much for being with us, and we will be in touch. Thank you.